Hi, my name is Jennifer Cameron, and I'm going to be talking today about preventing chronic kidney disease in the elderly. Vulnerable populations are those with a greater than average risk of developing health problems by virtue of their marginalized sociocultural status, their limited access to economic resources, or their personal characteristics such as age and gender. Vulnerability is both an individual and a group concept. Even though an individual is a member of a vulnerable population, it does not necessarily make them vulnerable. Duchesne in 2012 states that anyone can be vulnerable at any given point in time as a result of a life circumstance or response to illness or events. Being vulnerable increases morbidity and mortality risk. Examples of vulnerable populations include the elderly, high-risk mothers and infants, patients with chronic illnesses, disabled patients, patients with HIV and AIDS, mentally ill patients, alcohol and substance abuse patients, homeless people, and immigrants and refugees. For the purpose of this study, the vulnerable population will be the elderly with chronic kidney disease. The elderly ages 65 and older are particularly vulnerable due to multiple factors such as frailty, functional decline, cognitive impairment, and multiple complex health problems. Chronic kidney disease is defined as a glomerular filtration rate, or a GFR, below 60, or by the presence of kidney damage for 3 or 4 months. Kidney disease is the ninth leading cause of death in the United States. The stages of CKD range from 1 to 5, with stage 3 indicating moderate reduction and stage 4 indicating severe reductions in GFR. Stage 5 indicates patients who are on dialysis. Prevalence of CKD does increase with age. The incidence rate among patients aged 75 years or older was almost 7 times that of patients ages 20 to 39 and more than twice that of patients aged 40 to 59. Causes of CKD include vascular disease, cardiovascular disease, diabetes, hypertension, obesity, age over 60, family history of CKD, and ethnic and racial minorities. Health disparities is defined as inequality with respect to quality of care, access to care, health status, and health outcomes, as well as differences that exist among some populations within the U.S. in the incidence, prevalence, mortality, and burden of disease and other adverse health outcomes. In the United States, racial, ethnic disparities have been shown in the incidence, prevalence, and treatment of CKD. It was found that certain racial ethnic groups fared worse than their white counterparts with respect to the treatment or outcome of CKD, and that these disparities were that of a negative nature. African Americans, Native Americans, Asian Americans, and Hispanics were 3.9, 2.7, 1.6, and 1.5 times more likely than white Americans to develop CKD. High-fat diets and physical inactivity is thought to occur at higher rates among those racial and ethnic groups. An increased sensitivity to high levels of dietary sodium can also help explain the more rapid deterioration of kidney function seen in hypertensive African Americans. Reduced socioeconomic status also negatively affects a patient's access to care because despite having the greatest need for medical care, the poorest individuals often receive the least medical care. In the U.S., studies show that racial ethnic minorities are much less likely than whites to be referred to a nephrologist and undergo renal replacement therapy in a timely manner due to socioeconomic factors and lack of medical insurance. Delayed referral of patients with CKD to the nephrologist limits the potential for timely interventions that could slow disease progression or prevent complications. In my office, we recently had a nephrologist join our internal medicine practice. It was brought to our attention after he reviewed multiple charts that the providers in our practice, including myself, were often not diagnosing CKD in its earliest stages, which can prevent progression of disease and missing out on identifying reversible causes. So thus it was determined we needed to come up with an action plan. So my clinical question is, in the elderly with chronic kidney disease in the primary care outpatient setting, will a 6-month CKD awareness program decrease the number of elderly patients not identified properly with a diagnosis of CKD and improve clinical outcomes upon retrospective chart review. In order to correct this problem, it was felt we needed to come up with a CKD awareness program. A retrospective chart review using the electronic medical record will be performed. All charts of the elderly 65 years and older from a 6-month period will be reviewed, focusing on identifying the number of elderly patients that were not correctly identified as having CKD. The CKD awareness program will then be initiated in the practice for 6 months using an interdisciplinary approach and focusing on the elderly population 65 years and older. Primary prevention measures would include patient education and reducing risk factors which increase the risk of CKD. The nurse can help provide education on lifestyle modifications such as smoking cessation, maintaining normal body weight, exercise, diet modifications, decreased salt intake, and decreasing alcohol and caffeine intake. Secondary prevention, which is the early detection and treatment of a disease, would be accomplished by monitoring the patient's lab work to measure the renal function and the GFR. This is where the lab personnel comes into play. Then based on these results, the patient's meds would be reviewed to find any reversible causes of the CKD. Pharmacists play a role as they provide a list of recently filled medications and track compliance with meds. Based on the stage of CKD, referral to a nephrologist might be considered at this time. Also, collaboration with other treating physicians is necessary. An example being a patient who has CHF who is being monitored by the cardiologist and receiving diuretics, which can worsen the renal function. Tertiary prevention is aimed at preventing or delaying further kidney damage and loss of kidney function so as to reduce the prevalence and incidence of end-stage renal disease and other complications. A dietitian can be helpful during this stage to provide dietary counseling. Medications such as ACE inhibitors or ARBs can be used to slow the progression of CKD. Also, measures such as strict blood pressure and blood glucose control, treatment of comorbidities, and patient education is important in this stage. Goals of the program will be to identify and manage the complications of CKD, slow the progression of CKD, decrease the number of elderly patients not properly diagnosed with CKD, and to identify and manage associated comorbid conditions. Stakeholders refer to a person or group in an organization who has a direct or indirect stake because they can affect or be affected by the policies, actions, and objectives of the organization. The most important stakeholders in this CKD awareness program will be the patients, as they will be the ones positively impacted by the program. The office medical staff is another group that is a huge stakeholder in this program. It will take getting the other providers involved in the CKD awareness program. Without the other providers' participation, the magnitude of the program's results will not be as significant. The front desk staff will be important as they will assist with scheduling follow-up appointments and will provide reminder phone calls prior to the patient's appointments. The nurses in the office will assist with providing patient education information on CKD, educating on lifestyle modifications, will assist with ordering lab work and monitoring vital signs. The office manager is also a key stakeholder as she can help elicit participation in the program. The office manager has a positive interest in the program's success because successful implementation of the program can lead to other clinics following and can also lead to a profit for the office. The information technology staff will play a huge role as they help run reports when doing the retrospective chart reviews and help with assessing the data from old visits. The organization's chief medical officers would be key stakeholders as they encourage participation as well, because when patients are properly diagnosed with CKD in their medical records, it brings money to the organization, which would be cost-effective and profitable for the organization. Other key stakeholders would be nephrologists, because it is highly unlikely that all patients with CKD will be able to be seen by a nephrologist due to the current and projected shortage of nephrologists nationwide. Thus, having the nephrologist on board with the program is vital as the primary care providers can take primary responsibility for managing CKD in the earlier stages, and the nephrologist can influence the program by giving specific instructions such as when to refer and can serve as a consultant if needed. Yes, there will be challenges to this program. The key to overcoming challenges is to identify and assess possible obstacles to program development, implementation, and evaluation. Possible challenges in the CKD Awareness Project include difficulty getting all providers in the office to agree to participate. The other providers might be hesitant to initiate the project because they are already pressed for time due to the demands of Medicare meaningful use. Some providers might feel that primary and secondary prevention of CKD are not as important and that they shouldn't intervene until CKD reaches stages 4 and 5. Other challenges would include the patients, as CKD is usually asymptomatic in its earliest stages. Patients might be reluctant to change their medications and make lifestyle changes if they feel well and do not have a sense of immediate danger. Another barrier to the successful application of the program is related to the lack of recognition by health plans and Medicare of the importance of focusing on this high-cost CKD population. However, the early diagnosis and treatment of CKD can prevent costs in the future of a patient on end-stage renal disease. Some solutions to the challenges would be showing the positive impact the program would have on the office. It would bring in more money for the office and result in better patient outcomes. To help promote participation by the other providers, it would be explained that the retrospective chart reviews would be done by the author and that they would only be responsible for identifying the elderly with CKD. Challenges of the patients not wanting to comply could be dealt with lots of education by the DMP. The DMP can educate the patient on the long-term effects of CKD and potential end-stage renal disease and encourage participation in care. The measure used to evaluate the quality and effectiveness of the CKD Awareness Plan is a retrospective chart review. The chart review will be performed using the electronic medical records of our organization, reviewing all charts of the elderly 65 years and older from a 6-month period. The chart review will identify the number of elderly patients not correctly identified as having CKD. Then once the program is initiated for 6 months using the interdisciplinary approach, a retrospective chart review will again be used, with success of the program being that the number of elderly patients misdiagnosed with CKD is decreased and improved clinical outcomes. Technology offers many possibilities for designing unique interventions to impact population outcomes. Personal health records, which our organization has and we encourage all patients to use, are a set of internet tools that patients can use to coordinate their personal health information. They are used to track their complete health histories, including treatments and current medications and lab work. This information is maintained online and is accessible to the patient and healthcare providers who have been granted access. They facilitate the sharing of up-to-date and accurate health records between patients and providers. However, it is important to remember that we are going to be dealing with the elderly population, and not all of them have access to computers or as good and knowledgeable about the computers as the younger generations. Using electronic medical records enables providers to share medical information with each other. At my organization, any patient that has labs in the organization's 4 hospitals or outpatient clinics, the results will show up in the computer for all providers to have access to, so that the providers can look at trends in the lab work, which is important with diagnosing and managing CKD. The use of automated reminder phone calls are important. The system will call the patient 1 to 2 days before their appointment to remind them of their upcoming appointment. Since implementation of these phone calls, the number of no-show appointments has decreased. The electronic medical record that we use has information that can be printed for each patient on each visit based on educational level. They can then use this information, take it home, and review it with their family. In summary, the DMP can play an important role in caring for the vulnerable population of the elderly with CKD. The Interdisciplinary CKD Awareness Program can reduce the number of misdiagnosed patients with CKD while reducing disease progression and improving clinical outcomes. I look forward to any questions that you might have, and thank you for listening to my presentation.